there's more coming out, but for now, this is the focus of today's discussion. Before I go on, I don't have any disclaimers or any conflict of interest financially to disclose at this point. And also this information is really intended just for your information and really not to influence you in any way, just to help you make decisions and also promote the facts versus the myths in regards to the vaccine. So I will be focusing on just give you a synopsis of the COVID viral infection, also an overview of the late stage of the vaccine candidates in the United States. I'll focus on the concept of the messenger vaccine, as well as understanding the efficacy and also highlighting some of the safety concerns. And also give a little overview, as this is also changing, of the registration process and distribution process for the vaccination, as this has been also a big question in the community. And we'll leave it up to questions and answers at the end of the session. So what is the COVID virus? This is just a schematic, basic schematic overview of what the virus. I think we're all familiar with it now, seeing it on the news and with all the spikes. So if you look at this viral structure, just imagine the virus is cut in half or sliced. What do you see on the inside? So what I want to take out of this is really what happens under the cellular levels of these spikes. It really goes back to the proteins, which are the focus of the treatments now that we're targeting and the vaccinations that we're targeting, which is it has an envelope protein, lipid membrane, as well as the spike protein, which also specifically is a coder for the envelope, for the nucleus protein or the enclosing RNA. So why it's a big deal, and it's utilized in order for the virus to attach to the cell and then replicate itself into the human cells. So all these 4 proteins are relevant because they're all needed in one way in order for this virus to invade our body. So I tried to make it into a simplified schematic, just overview. I'm not going to go into the details of mechanisms. It's very basic, and the focus is just how does the virus go into our body. Viruses don't replicate alone. They need human bodies or really a live being in order to replicate, just like the rest of the humans. And the easiest way is really getting into the human cells. So if we look at the SARS-CoV-2 virus, as I mentioned earlier, it does have the different proteins on its surface and really the viral RNA that carries all its genetic material, and why it makes it unique, and also why we are seeing mutations. This is not different than any other viruses that we see, such as the flu, the Ebola, even the HIV viruses. They kind of have similar structures. However, the encoding is a little bit different. The way the viral genetic is different and why they have different names. But there's many viruses that go under that SARS description. So imagine this yellow, black line here, that's part of your cell as a human. And specifically really lung cells, that's where we are getting the virus to get into our body and then attaching there and then kind of going from there and infecting the rest of the cells in our body. In order for the virus to attach to the cell, it needs to bind to something. So the ACE2 receptors, those are just kind of binding block. The easiest way to think about it is like Legos. You need 2 things to attach in order for something to be built. So the virus attaches to the ACE2 receptor. So that's called the binding to the cell. It binds to the cell, and we also have another activator, which is this green block here, which the easiest way to think about it is the fusion and entry. It's the easiest way, it slices the virus in half to allow the virus to, once it attaches, to release everything inside it into our cell. And that contains the mRNA as well as a lot of these proteins that are needed for the virus to replicate. Then there's genetic material that helps us to transcribe it into our cell in order to take over our cell. This is really what happens in reality. And then it integrates itself into our nucleus and cell, makes new viral material. It translates itself into a new virus independent. And then it tries to assemble itself to make itself again after it takes your own body to replicate itself. And then from there, it buds out of your cell and then it goes on to infect other cells. This cycle takes about 1 to 2 days to happen. And that's why when patients get exposed to the virus, you don't see symptoms from day one. It takes about usually about 5 days as an incubation area before you start showing symptoms. And it kind of makes sense because this cycle, and this is millions of virus particles that we're talking about. It's not one or two. And that's really what triggers the immune system to activate once it recognizes all these viruses are out, the protein is there, it goes to infect other cells. As well, it induces the strong inflammatory response. And you've probably been hearing a lot about this in the news in regards to the cytokine storm that you tend to see usually about 7 days into the infection, because that's when the body recognizes and it tries to attack the virus. But depending on how strong our immunity is, if we have other chronic diseases, if we have inflammatory diseases at baseline, this can range from mild symptoms to very severe and also death, depending, because the body tries to fight the infection, but also it ends up fighting some of the organs because of the hyperinflammatory response. So it ends up acting like an immunological disease in some situation where we are utilizing immunosuppression such as steroids and other agents that we tend to use for transplant patients and just immunological diseases to just settle the storm in order to improve survival. So it's a very complicated, it's almost a fine balance between reversing the inflammation, but also you have to be careful because of the over suppression can also lead to complications. And that's been really a challenge for healthcare providers over the last 11 months, is just finding the best regimen for patients. And we're yet to find really the best fit and who are the patients and can we design regimens for them? And we're not there yet. So moving forward, we're all aware the numbers are changing continuously. This is just what was accessed yesterday, but we are considered at a high burden and growing. The viral count is still growing in the United States. We have not really been out of the pandemic. And we all see it on the news. You can also track it on the WHO, and also the CDC has trackers even to your city level and like state level if you're interested in looking at those. Why this information might not be relevant by this afternoon as it's continuously changing. But the point to take here is that there's been over 27 million cases in the US, and we're talking about, again, less than a year. And the total deaths approach over 482,000, which are not small numbers to see. And these are documented deaths. There might be other deaths that we haven't witnessed because people died at home with no confirmed testing. And those are some of the challenges that we're seeing. But again, very high numbers and something just to be aware of. And it's a global pandemic and not just specific to a country. So why worry? So that's kind of a question that I always get or I hear. Well, if the rates are only about 1% death, why do I have to worry? I think it's better to look at the big picture and really look at the total number. So when we look at the COVID case death rate, or we call it also CFR or case fatality rate, which is the risk of death due to confirmed cases of COVID. Again, it has to be confirmed. And it might be higher because, like I mentioned earlier, we don't necessarily have confirmed cases in every single scenario. The US death rate ranges from 1.7 to 6.2%. And this is here in the purple line that I have here. I have arrows just to kind of show it. And this graph is only representative of a few countries. It's not the whole globe, but there are other countries that are up to 20% death rate. So if we just look at the United States alone and we take the lowest risk, which is 1%, we are like, if we stay at that rate, that's a minimum of 3.3 million deaths, which is a lot of patients dying. So why I think we're always talking about controlling factors. So the numbers, like I said, but I mean, the numbers have been changing also over because we have more meds to take care of the patient. We have multiple layers just from our own experiences that we learned over this pandemic. And also the vaccine now is adding another layer to hopefully cut these numbers down and then kind of just make it more of a steady rate, maybe seasonal in the future or whatever the future predicts for us. One other pointer that I wanted to make here is the myth where, how is it different than the flu? It's an RNA virus, it's a respiratory virus, and we deal with the flu every year. The fact is, you have to look at all the numbers. The number of deaths due to COVID exceeded what the total flu death rates in the last 9 years. So it's not small numbers. Again, this is with treatments that we have in choice. It's a lot more complicated when it comes the way it's affecting our body than the flu does. And the flu's been around for decades now, right? So our bodies have been exposed to it before. It has probably some memory to it, even if we have future infections and the vaccination mismatch. We've been exposed to it. So it's a little bit different than the COVID, which is all new for our bodies, and why it's such a huge problem when it comes to body's responses to it. So even after recovery, when we say full recovery, the patient really recover after if they survive COVID. What we're finding now that we've been into this for, like I mentioned, about 11 months, it's really, there's complications, and a lot of it goes back to patients' baseline demographics, baseline disease state, what treatments they received, as well as how bad was the inflammation during their course of infection. And the symptoms are lasting for more than 90 days. On an average, in about 1 out of 7 adults that are recovering are having lasting symptoms. And those range from joint pain to high blood pressure issues, irregular heartbeats, like arrhythmias have been a very common thing that we're seeing in even young people that have no cardiovascular disease, sleep disturbances, chest pains, and as well as cough and shortness of breath because of the scarring that is left behind, as well as spinning, skin rashes, clotting complications has been something that we've been observing, brain fog, and also infections, both bacterial as well as fungal and opportunistic infections due to the treatment regimens, and also the overall imbalance of the inflammatory state that the patient ends up with. And probably we're going to see more. It's just, this is what we have seen up to this point, and we'll learn more as we track patients and see if we can correlate it directly to the disease also. So what do we do to disease control and manage? What is our goal with, how do we put a control for this disease? And I'm not going to talk about treatment regimens because that's not the focus of this presentation. It's really more infection control and another layer, which is the vaccine. So the overall goal of COVID management or control is really just to prevent infection, prevent ourselves from getting the infection. However, that cannot be avoidable in some situations. But if we follow the measures correctly, I think the risk goes down significantly. But even if the patient catches an infection, we want to prevent severe disease, the need for hospitalization, transmission as well, minimizing the morbidity, which is the complications that I just mentioned, and also the mortality, death at the end of the day. So the easiest way to kind of put it together, I don't know if you're familiar, if you've seen this before, we follow this successive layered model, and it's really what it is the Swiss model, the cheese model, where even if you put multiple layers in place, there's always going to be a loss to not prevent an error or an infection from happening in this, unless you have multiple layers, and it all starts from following it, but also following it appropriately to prevent an incident from happening. So the metaphor is kind of very simplified to explain the Swiss model. There is no slice that's perfect. Every slice has holes in it, and the holes don't tend to line up if you follow the right path, but in some cases where the holes line up, you can easily end up with an error. So how does that relate to COVID? And then the Swiss respiratory virus pandemic defense. We have personal responsibilities as well as our shared responsibilities that we follow. And many of you have seen this over the months, right? And we follow it from physical distances to wearing masks, but wearing masks appropriately also, not just putting a mask under our nose. Hand hygiene, how we cough and protect ourselves and others, avoiding big groups, just filtration, ventilation systems, financial support to kind of provide us with all these tools, quarantine and isolation. And we've seen that happening often. We haven't really been back to norm since last March. And the additional layer is the vaccine. So having more of these layers and following them appropriately will decrease the risk of an infection. It's like almost you're driving a car and you're trying to make a left turn or right turn. If you look at both ways and you're not looking at your phone and following all the measures that would protect you, your risk of getting in a car accident is very minimum. So it's very similar when it comes to COVID protection and protecting yourself from the infection. But like I mentioned, the vaccine is the additional layer that we just incorporated in this, because it's really about sustaining, and are we going to live in quarantine and isolation forever? Probably not, just to function as a country and as a globe. So we want to see how the vaccine is going to add to that, and hopefully can alleviate some of the other things, just so we can have some normality back in our life. So moving from here is, this is kind of just an overall understanding, what is COVID, what are the complications, how do we prevent it, and really where does the vaccine play in this, and what are the, I think there's a lot of questions about the production of the vaccine. Why did it come on the market so quickly? And is it not safe? I will also briefly talk about how it works, specifically on the mRNA or the messenger RNA mechanism. Does it work? Is it safe? Is it studied in special population? Is there any data related to that? And then the overall distribution and registration process that we have, and also that might be changing, and how to follow like the changes for that. So in regards to the paradigm of the vaccine production, traditionally, we always followed a traditional way of approving vaccination, but those are cases that we haven't had pandemics in years or decades, until the 2013 and 2016, which did not really affect us here in the United States at all, or as much. The Ebola, the Zika, there was an agreement to have also a pandemic paradigm for vaccine production. It was started for Zika, and then it kind of, it did not affect us here in the United States, so we really did not see the impact of this. But traditionally, there's a very clear scheme on how things get approved and how do we end up approving them by the FDA. And it takes years for that to happen. First, you have to identify like what you're studying. You have to identify preclinically how you study things, which is usually in animal models. Then you go into a first human trial, which usually just overall determining what dosing to use, and efficacy, where does it work or does it not work, and evaluating the trial in real human, like focusing on the disease stage, which would be COVID in this case, and then getting the vaccine license. And then you also have large manufacturing happening throughout, like later in the phase, but it's never early on. With the outbreak of the pandemic, it's a little bit different. Everything is happening at once, and it all happened at once. So once we heard about the pandemic, that whole process came back to life, and the government funded so much in regards to, it was a huge risk to take, where how if the vaccine did not work, and how if there was harm with the vaccine. They still asked the manufacturer to start making the vaccine and investing money in making it, while the studies were being designed and people were volunteering to be part of these studies. And we're lucky that this kind of came out to be true, where we do have vaccines now that are effective and also safe. Otherwise, it would have been a risk. So I just wanted to kind of bring it back to that, where it's not something that did not follow the criteria of how vaccines are produced. It was just done like in a short develop and overlapping phases, no sequence of years. It was all happening within weeks to months. There are 8 different vaccines that are being studied right now, and they range anywhere from live attenuated vaccine to some that use the viral vector. Some have DNA vaccination processes, some have subunits of the virus itself. But really the 8th one that we have now is really the RNA or messenger RNA vaccines that I will be focusing on, because that's where we have the data right now and what we're utilizing in practice. In the US, there are potentially 5 different vaccines that we might have. The 2 that are now have the emergency utilization approval are the Moderna vaccine and the Pfizer vaccine. And those are both messenger RNA vaccines. They kind of work very similarly in regards to encapsulating the messenger RNA, which is just genetic material of the RNA of the actual virus, which is all synthetic. It's not a real virus that we're injecting in our body. And then you have these other methods. I know the Johnson & Johnson also is going through the approval process, and we might see it's a one-time dose versus the messenger RNA vaccines are 2 doses. I think the question that comes up is the 1 dose not as good as the 2 doses? Just like any other medication, these are characteristics of how drugs, that's why we have medications that you take once a day, some that you need to take 6 times a day or 4 times a day. It all depends on the base characteristics in the stability of the drug and how long really does it work in your body to determine if you need multiple dosing for it. And I think for now, the data that we have is based on, it is still short term. And we also have to remember the people that volunteered their bodies to be in these trials before they even came to us, which was thousands of patients. And they're still being followed long-term to see what is the long-term immunity, right? That's the biggest question. How long am I supposed to be immune with this? When they first came on the market, it was usually like up to 2 months is all the data that we have. But now we're seeing more. We're seeing countries that are massively vaccinating the population, and we're seeing the reduction in hospitalization rates and infection rates. So that's something good to look forward for. And you always have to relate it also to your, like what happened to people that are getting infected with COVID infection. We know the immunity in most patients is lasting for 6 to 8 months when you have a natural immunity from the infection itself. So it shouldn't really be any different, specifically with the type of immunogenicity or like how much antibodies we're producing from these vaccines compared to the natural virus. And one thing also, based on some epidemiological studies and also some tracking of other infections, the bigger question, even if our immunity goes down from an antibody count, we always have something called a memory in our body, right? It's called the B cell or the memory cell that will remember that we were infected. So the question is, does that mean it will protect us even if our numbers are going down, and how much of a booster do we need? So all these things, I think we still don't have an answer, but as we're going, we're learning more and more, and those patients are still enrolled in the studies that were initially in those studies. And I'm hoping like we see more, and there's continuous data that's coming out to support some of that information. So I use myself as, just like many of you, right? It was all new, even though I am in the field, and I dealt with COVID from day one in regards to deciding what treatment and the challenges that I witnessed and the complications that we're seeing. So the questions I asked myself to help me decide, do I take this vaccine or can I wait for the vaccine? The first thing, I think you have to question yourself, what is your risk of COVID infection? Is it something that you're immune to, which none of us are immune to it, right? I think it's just our responses might be different, but even for those that respond mildly, what does that mean from a complication standpoint? We still don't know if people will have a complication, even if they didn't have such a flare-up at the beginning. What's my risk of complication if I get infected? Because that's, I think, a much scarier thing to think about with all these diseases that people are ending up with that they never had to start with. And these tend to be chronic, more long-term, and things that we still don't know the complexity of them and what impact does it have on the morbidity of the patient. And what is my risk of death from the infection? The biggest question to me is, what is my risk of disease transmission to my family, friends, and really to the community? Because we're all out there, even if we're isolated, we're still going, some of us are still going back to work, but also to grocery stores, and there's still people out there. Are we going to go back to schools? And all these things, I think, were coming to mind to help me decide. And then after that, I had to read the data and understand it. Does it work? Is it safe? And also, will it help me go back to my normality? So going from there, I wanted to just introduce the first thing, again, we wanted to talk about is how does it work? mRNA, the method of mRNA, it's not really a new method in any way. We use it now for cancer research. We use it in immunotherapy for cancer patients. And I think that's the future of even treating cancer, mainly because it's very targeted. You don't need to overwhelm the system with toxicity of chemotherapy. And we're following these. And I think that's just the future of chemotherapy in of the future targeted cell genetically and patient-specific treatment. And it's not something, like I mentioned, that's new. All it is, it's very easy to make compared to growing vaccines in eggs. And that's what happens now with the flu. And if we look at the flu mismatches from vaccination, the virus is smart enough to recognize and replicate even in chicken egg. And how do I keep mutating myself? And we see mutations within a year. After the successes with this mRNA vaccine, I think the future is to even explore it for flu. This way we can modify the vaccine as we go, especially if it happens in the other hemisphere. And then by the time we get it here in 6 months, our virus, the change can be made easily without a loss. All it is really learning the genetic material of these viruses and being able to incorporate them synthetically and allowing your body to recognize them. And just overall, I think it's the best way to protect our body and just prevent diseases overall. So that's kind of just a little bit of a nutshell of the messenger RNA. All the vaccines that are coming on the market eventually or will be reviewed and approved are based on that basic mechanism of how the virus works. It goes into our cell, it utilizes the cell to replicate itself or make it assemble itself and goes out. The first mRNA vaccine, again, it's a 3-step model, the easiest way to think about it. We are using, like I mentioned earlier, the RNA vaccine genetic material. So it is an antigen. All it is, the way I think about it, it's a coder or a messenger. It's not something permanent. It's almost where someone described it, and I loved how it was described. We use it almost like a sticky note. I write my to-do list for the day. I don't need it tomorrow. I'm utilizing that method to know what I need to do today. And after I'm done, I rip it and it's gone. And our body does that kind of, and we have proteins, that's how we live, right? Like we're based off of proteins, our cells are based off that. And why when we have disturbances in these proteins and that are normally there, we tend to have these types of weird diseases that our body tends to acquire. So think about it that way. I think the fear is, well, is it gonna stay in my body? Is it gonna change my DNA? It's not really needed. It's a way to just incorporate and trick your body to know, to recognize that there's that spike that we have on the virus and kind of trigger an immune response to where your body takes that spike, which is that little green circle here, which is, again, it's synthetic. It's not a real virus in this situation. And it goes and presents it to other cells to kind of trigger a memory. And that usually induces inflammatory responses, which is your T helper cell and your B cell, which also gives you your long-term memory. So that's really how it works. And then after that, the RNA is gone, and really your body have developed that immunity against that spike. So if you ever get the infection, your body recognizes how to fight it before it attaches to your cell, and then it goes in and replicates. So it blocks it before it enters your cell. And there's methods where we might have stuff that work inside the cell, but for now, this is how it works in our body. So it's, like I mentioned earlier, it's not a live virus. mRNA never enters the nucleus of the cell, which is where our DNA genetic material is kept. And the cell breaks down and gets rid of the mRNA soon after it finishes what it's supposed to do. That's why it's called a messenger. It's not something permanent. There are 2 vaccines, like I mentioned, the Moderna and the Pfizer vaccine. They tend to have, I think the bigger question that I've been getting, what are the ingredients in the vaccine? Because we're used to medications, right? Like some have lipids in them, some are made of gelatin. And this is all published on the CDC, and also you have the right to call the manufacturer and ask, and I did that because they have to provide you with all the information that's provided. They're both kind of similar in regards to the RNA encoding viral spike. It does have an inactive lipid. So the lipids are based on cholesterol. And I think the question that came up, is this like based on gelatin from pork and different entities? There's absolutely no animal product. The only thing that from the Pfizer product, they did use at one point in the production of the vaccine to get it to a stability. cow milk, but it's not something just to stabilize, but a lot of it is the veggie base and actually synthetic material. One of the other things that we also watch for is the polyethylene glycol. So it's called a stabilizer. It's not anything that makes, these are inactive ingredients, but it kind of helps the lipid be stable. And why these vaccines have to be frozen at high temperatures, because they're very fragile, right? Like it's something you are dealing with an RNA, it's a lipid material. And we've seen polyethylene glycol is not anything that we don't see. It's probably in tons of packaged food that we have now. It is available in other medications, specifically chemotherapeutic agents that we use. And it's really just to stabilize the drug. So it also might have a factor in also why some patients are having allergies. Mainly it's because probably people have allergies to these products because of previous exposure to, but they might be vivid allergies, and it's not very common. We've seen some anaphylaxis, but people were known to have these types of allergies. So when the patients enroll for these, there's a questionnaire that usually asks you for all these things. And we tend to also ask the patient when they come to the clinics, are you allergic to, and we give examples of some of these products that, and medications specifically, that if you've had an allergy to. So it's something we always say, discuss with your physician or you with your pharmacist if you're not sure, but there's enough data there to show what products we have in the market have polyethylene glycol. And some of the other vaccines also have another product that also is seen in other medicine and also food that we ingest and maybe develop sensitivity to over time. It also has sugar and also just basic salt in the Pfizer, which is sodium chloride. They're both 2-dose series. The doses is a little bit different. The Pfizer has a 30 microgram and it's the same for first and second dose. And really what it is you need the 2 doses, otherwise the vaccine does not have the full efficacy. Because what it is, you get the first dose to really induce that initial reaction. And then so that when you get the second dose, the patient has that booster effect where then you can develop some of these memory cells and higher immunogenicity, right? Because with exposure, you tend to build that up instead of just 1 dose. And that's how they were manufactured. I mean, this might change in the future if we learn that maybe you don't need to, or you need a 3rd dose. But for now, there's enough data sufficient where the intention was to give 1 dose, but it was a much more effective with the same dose to give it twice within a series to help the body make that antibody, because we don't make antibodies day 1. It takes about 14 days. Even with the disease, it does that because you're getting over an antigen and then your body needs time to make that memory for it. So we are kind of strict in regards to the timing, in regards to the 21-day between the 2 doses for the Pfizer and the 28-day. However, there has been situations where I've had patients come and say, I can't make it at 21 days or 28 days. The CDC came up with this recommendation where you can wait for 6 weeks. We don't readily recommend it if you are able to get the vaccine within the allowed period, but there's scenarios where if a patient is in a hospital, for example, for any other reason, or they have to be out of town, and even though we try to follow these as an exclusion criteria and let them, or there's something that happened, we can still use that 6-week mark. The other thing that comes up often, we specifically now with our phases, a lot of elderly patients require other vaccinations, such as the flu, which is seasonal, but also a zoster vaccine called Shingrix. I'm often getting the question, is there a problem if I get them together? The safest measure, and really mainly from you don't want to deal with side effects with both vaccines, and really give your body that immune period of 14 days to build immunity for one vaccine before you go into the other vaccine. So the recommendation is to wait for a minimum of 14 days. And unless there's like an emergency where someone has tetanus, for example, and they were exposed to tetanus, that is priority. We can't wait for the tetanus shot because the patient can get harmed because they got the COVID vaccine and it hasn't been within 14 days. You have to look at the risk for benefits. And these are all things that we assess day to day. Like we get these questions often when patients even show up to the clinic, but also with your provider. That's something good to address, and if you're not sure, to clarify. So I think we've all heard the efficacy from a specific number, like 95%, I think, and 94% is something that's been circulating. I mean, I'm not going to go into the details of how these, like to the level of the demographics. I'll just highlight the major things from an efficacy standpoint that we look at. When we look at efficacy, really, it's disease prevention and severity of disease, right? Like, did I prevent people from getting into the hospital because their body was able to help them fight? We're still in that transmission phase. I think we're still looking at, because I think we have to look at the massive amount of how many people we need to vaccinate and or the people get infected before we get to that steady rate where transmission is very low. And I think there's a lot of hope based on other countries that have done vaccination with 90% of their population. They saw almost 40 to 50% reduction in both hospitalizations from severe infection and also disease, even though they had all the isolation methods in place previously. It showed that the vaccine is adding that layer of efficacy to all the other things that we have. So in a summary here, the vaccine, this is a Pfizer vaccine. It has a very effective, I mean, it's very effective when you look at added versus placebo at any age group, those between 16 to 55. And then when you divide it into categories, right? Like those over 75 had a 100% efficacy, meaning zero infection. And then kind of the list goes on. So regardless of how you look at it, it's evenly distributed among the age groups in regards to that, those red numbers that you have here under efficacy, 93 to 100%. What about ethnicity, right? That's the other question where did we have the right amount of patients in the studies? And also, did we see the same results?
Mm-hmm.
Okay. So it's kind of the same thing. I mean, the efficacy range is anywhere. The all others is kind of, it's all others, right? Like it's very hard to tell, like, what is it? Is it different depending on where they registered these patients? But the way they broke them is into white, Black, or African-Americans, Hispanics, non-Hispanics, and all others. And that's how the all others is probably the Asian group also is in that group. And the efficacy was about 89% in that. It's still very effective. When you look at the flu vaccine now, it's about 40 to 60% effective season to season, and that number keeps going down. And I think it's because of the mutations that we see and other reasons. So these are pretty good numbers when we look at efficacy of vaccines and how drugs work. This is, again, just a schematic overview here of the blue line on top is the placebo people that just got saline versus those that got a Pfizer vaccine. And like people are referring to this, this is probably the perfect model of what efficacy is in science, where it's a clear linear protection versus if with the placebo, the number of infections and incidents will continue to go up. I'm not going to go into the details, but it does show that with the first dose, patients produce about 52% efficacy within 7 days. And then with the second dose, with the booster, you go up to 95%. There's still a 5% chance people will not get immune. And it's probably due to, they excluded a lot of patients with immunosuppression. It might be just their own factor. They might be receiving meds that block the way the virus works. And I think now that we're using it in our populations, there's no harm. But I think the antibody testing eventually will teach us who are these 5% of the patients. And that happens now with the flu vaccine. Some people do not build an immune response, but a very small portion of the population. In regards to the Moderna, the same thing, the numbers are very similar, 86 to 94%. The numbers were a little bit lower for over 65, but again, 86% is a pretty good number compared to other vaccines that we see on the market. This was true for all ethnicities in regards to male and female, as well as white and communities with color. The efficacy was 97% in the communities with color, which is also great to see, specifically because we saw the effect of COVID early on, and it did affect a lot of communities with color like early on, and we saw that in our own state. And I think this is something great to see and kind of like to share. And I think these numbers obviously are there for a reason, and they're very well controlled. I think when you're in studies, there's a lot of follow-up that happens. I've done studies myself. multi-center and randomized, and I saw the level of follow-up that happens. It's very detailed, like, and that's why the package insert tend to be so big of drugs. Some of these might not be even related to medication, but we follow, or even if a patient coughs or sneezes, all that is captured when it comes to medications and safety. The same thing, the Moderna vaccines, in regards to the projection model for the intent to treat, very similar to the Pfizer, very steady rate of infections for those that got the vaccine versus those that got the placebo sodium. So overall, like both vaccines, when you compare them to efficacy, 94 to 95% when you look at the whole population, not just strategic stratify for groups. And the prevention of severe disease, also it's 75% for the Pfizer and 100% for the Moderna. So overall, like there was benefits with both agents in regards to these two major things that we focus on preventing, and also preventing complications in the future. So really, in a nutshell, the numbers show that it works. It's just, I think we need to learn further, how long is this protection going to continue? When can we be freely able to take our masks off and go to normality? These are the things that we're still waiting to learn about, but I think there's hope and positivity, at least based on what we're seeing day to day, but I can't speak to that because it's not published or for me to recommend it at this time. But it's always something. The CDC is great when it comes. There's nothing hidden. The WHO and CDC has all that information. And it's a great reference that we as healthcare providers refer to it, and it's open for the public as well. It's not secret information, and it's good to keep track of the facts versus, and I think there's a lot that's happening with social media and like that we have to be aware and like know the facts before we assume these are all facts. The bigger question than the efficacy is it safe? I think we already know about the COVID infection and its safety in long-term complications. What about the vaccine? So we mentioned with the vaccine, it's a very small dose of not a true virus, right? So when we're seeing people getting sick after the vaccine, it's not really, and we're always clarifying, that's not the sickness of an infection. It's not going to be COVID. It's a normal response, and actually it's a good response when a human body responds to something, and that's what our body's job is to. There's so many toxins out there in the environment, and our body is continuously fighting for us, if we have a good immune system, to protect us. So it's not a bad thing to have side effects, to have fever, to have muscle pains. That means there's actually a trigger and your body is responding to the vaccine. However, it's not something that we're seeing with the virus where it stays for days and weeks. I had the vaccine. I mean, I did have side effects with my first dose, with my second dose. They were my typical side effects, which kind of also was a relief that I noticed them. But also we have to know, if patients don't have these side effects, doesn't mean the vaccine does not work for them. It's really just how our bodies respond to different things, and just how it reflects like the immunity overall. But when you look at the two vaccines, they're very similar. The overall side effects with the first dose were about 1/3 of the patients, and they ranged anywhere from muscle pains to fatigue, headache, chills, which we see with other vaccines, fever, local injections, redness, and swelling around the injection site, but those tend to be a little bit less. With those two, there's more, right? Because you're boosting, just like we're giving a second dose to boost our immunity, we expect our side effects to be higher, and we want them to be higher. It's not much higher though, so it's a 10% difference compared to the first dose. But I think the bigger question is, what percent of patients had that grade 3 where it impairs your daily activity, you couldn't go to work, or you couldn't get out of your bed for a day? That was between 1.5% for the Pfizer and 4%. Again, those did not lead to hospitalizations. These were daily activity. You might have required like Motrin or Tylenol to mask your symptom and help kind of alleviate some of that. But that's really, there was no mortality or the grade 4 that we refer to from the vaccine that was observed. It's also good to put it in perspective on how do the side effects compare to other vaccines. Shingrix, it's something that every person over 55 is recommending, because catching zoster in an elderly age the mortality rate is very high. It has a lot more of a response from a side effect profile compared to the Moderna and Pfizer. It's about, I mean, kind of the same, but also it's a little bit higher. And why we tell patients it's good to separate by 14 days, especially those that are over 65, just to kind of protect them from having this pronounced side effect profile. The flu vaccine is only 15%, but also I have to remind you, the flu vaccine has been around for decades. So our body has seen it multiple times, even though we have different sequence of mutation that we adjust for. We've already developed antibodies to the virus, and not every sequence tends to mutate. So that might be why, if you looked at the data years ago, probably the rates were much higher. But this is kind of in today's day and where we are from a comparison standpoint. The vaccine is still considered contraindicated right now for people that have a known allergy to other mRNA vaccines, which we don't have those yet on the market, or if they have an anaphylaxis to, which is a severe allergy to the first dose. And we've seen that in Europe and like the numbers, but very small numbers. But what they're identifying, these people have already history of anaphylaxis to the polyethylene glycol or some of those products. I think down the line, like if this is something that we want to protect people and they have the desire and they have this allergy, like immunology might be in place to maybe do skin testing for these patients and see how do you protect them and still give them the vaccine. And really anyone, like I said, with the polyethylene glycol or immediate allergic reaction to the polysorbate 80, that one is more, it's not with the Pfizer and Moderna vaccine. You see it more with the Johnson & Johnson. And it's also an inactive ingredient that's found in medications and other products that we eat. So patients might have already allergies to those. We still assess patients like immediately, like while we observe patients in the clinics for 15 minutes. And then sometimes we keep them for 30 minutes if they have a history of allergy to unknown. To just injectable medications or vaccines in the past. And I've had patients kind of have that initial trigger response within 5 to 10 minutes of the vaccine where it's not rash necessarily, but just either like itching, like at the site of infection, which is fine. Our lymph nodes are very close to our shoulders and around our neck. And some people have it under usually you tend to see it under the underarm. We tend to see them for 30 minutes and most of the time there's no need for medications and it subsidizes and they go back to normal. I know we're at 9:56. I don't want to, I don't know, Carrie, if you wanna, do you want me to continue or what would you like to do?
Yeah, I mean, I think, you should continue on. There's a lot of great positive feedback.
Okay, very good. So these are just some of the special population that it's good to kind of just highlight who was in these studies. Like who did we include? There were some geriatric patients, there were some pediatric patient in the Pfizer study. However, we decided to just hold off on approving it for people that are less than 16. For now, there's studies that are happening right now for that, but I think we need higher data and to kind of see what's the efficacy. Kids, and we see them, even with the virus, the response is very different, right? The way they present is very different, but also you have some kids that are presenting with multi-organ failure. And we've seen that in Detroit, where that's kind of was the sign of that they had COVID. And that kind of ranges, and it goes back, I think, to people having maybe baseline genetic material, I'm talking about the virus and not the vaccine. But I think we need more information before, and that's normal, right? Like children always come after adults. But I think from a geriatric, they accounted for about 25% of the population that was studied. And these numbers were not small. We're talking about 30,000, like approximately 40,000 patients in both the Moderna and the Pfizer study. The racial ethnicity, as I mentioned earlier, I mean, I think here you see the numbers, but I think we're also seeing it while the vaccines are being marketed now as for emergency use, we're seeing acceptance, right? Differences between also different ethnic group. And why I think there's a lot of education and awareness that needs to be raised, and it's happening across and multiple levels. But The majority were white, right? Because there were multinational, international studies, and it depends on what country, right? Like you were studying in the drug and who was willing to be in these studies. Also, that's the biggest question of why you see these disparities here. The Blacks accounted for about 98%, Asians accounted for about 5% of patients, and Hispanics were about in the, 25 to a third range. So that's kind of, okay number, but now, as we use it in our population, it'll be kind of interesting to see at a much higher level what's really the benefit of using this in all these groups and the protection differences across the different ethnicities. Pregnancy also, there were about 23 patients in the Pfizer group and 13 in the Moderna that got pregnant. However, they did not have any adverse events in those patients. When they opened the books and saw which patients were, because it's all blinded, right? And when it's studies, you don't know who gets Pfizer or Moderna or who gets saline, and they do that just to minimize bias. But when they opened the books to see where were these events, they were actually in the placebo groups and were not in the vaccinated group. Other populations, there was a good group of patients with obesity, which is something we like to address mainly from a response, because we also saw that as a risk factor for COVID complications. Diabetics, people with high risk conditions, meaning like severity of disease, and pulmonary diseases, and also HIV accounted for about 120 patients for the Pfizer study, and those had to be stable HIV patients. And I think as we use it more, it'll be interesting again to see what the response rates is for all these subpopulations and why it's relevant to continue with the data and know what the evidence is out there. So in regards to pregnancy, there's now, even though, like, as you saw, the numbers are very small that were in the studies, the CDC, which is I have a spelling mistake here, the Center for Disease Control, ACOG, which is the American College of Obstetrics and Gynecology, and the FM position also themselves, they all three strongly recommend the vaccine to be offered to all pregnant women, mainly because it's not a live vaccine, and really the only contraindication to giving vaccination during pregnancy are live vaccines, because they can be problematic during pregnancy. mRNA vaccine do not use adjuvant to enhance activity. And the vaccine is broken down, like I mentioned earlier, very quickly by normal cells where it does not enter the nucleus. And the theory is that they don't alter DNA and cannot really cause any genetic changes. And we've been seeing a lot of pregnant women show up and receive these vaccines willingly, and mainly from a protection. We know at least the impact of COVID on pregnant. There has been cases, there has been harm and complications and leading to hospitalization. And really one of the antiviral agents that we've heard, which is remdesivir, was specifically being utilized for emergency use early in March, mainly for pregnant women, mainly because of the high level of risk for if the patients got COVID. So having protection makes sense, and the theory makes total sense of why this is recommended. So that's in regards to efficacy and just the overall vaccination. One thing I think I wanted to highlight here, because also there's a lot of, misconception, misunderstanding. Why are we not having the vaccine readily available? It goes really back to production and availability of the vaccine right now. And it all comes from the vaccine got authorized early in December for those two products. After that, usually there's a process called prioritization, where the CDC came up with two groups, which was the healthcare providers and the nursing home residents. And after that, they leave it up to the state to determine what criteria goes next. So that's what's called priority. And then from there is allocation, which means specific amount of COVID vaccine doses are made available to states. And then it's shipment from the FDA authorize it, and then it goes to different sites based on that. So really it's not controlled at the local level or health system level in any way. And a lot of it is federal to state based on their criteria. And then also it goes to distribution. The more sites we have in the state, the less number of vaccines you're going to see at specific sites, because the point of like Beaumont was one of the first sites to start a vaccination clinic, and we had huge numbers. But now as the state is expanding the criteria, expanding the clinics, we might see these numbers changing also. But we, from a ability, we can vaccinate up to 50,000 patients a day from the availability of staffing that we have at our clinic. And that is doable as long as we have the allocation. We keep assessing our supplies and also clinic visits based on what the state authorizes. Michigan so far received about 1.9 million vaccines, and about 1.6 have been administered, which is great, but we still have a lot to work on, right? And that's why we're in the different phases. And I think now with the Biden rule to make 200 million doses, hopefully that will be enough vaccine to provide to everybody that is willing to take the vaccine. And now if Johnson & Johnson comes with out and the availability, we'll have more choices to offer to patients, regardless of their age or ethnicity or whatever the case. So in regards to the state of Michigan, all this information is available on the COVID Michigan website, michigan.gov. It has the different phases. We are now at a state level, we're still in the phase 1B. And even for that, like I mentioned, the state is not, it's an allocation. They're not getting enough vaccines to cover all these patients. And that's why it starts at a specific period, but the intention is to continue. And then the goal is to hopefully have that. And then we kind of go from group to group. And there's restrictions on these phases. Otherwise, you're deviating from the emergency approval process. So in order to accommodate this, Beaumont has over 1 million, I think, patients registered for just over 65. That's beside healthcare workers. And like I mentioned earlier, we're able to administer vaccines for up to 50,000. However, we're only receiving about 10,000. And I think this week is even less than that. We had to cancel some clinics due to that because the state did not allocate, probably because the state was not allocated enough supplies from the government. So we're really only able to vaccinate about 2% of our eligible patients. So to minimize bias, we do have a random pick. We encourage patients to register at least, and it's really all random right now in our clinics, because if we hand pick, also that's a lot of bias. So we're hoping with time, these numbers will go up and we'll have enough vaccines where we can accommodate everybody without this frustration. And I kind of understand why it can be frustrating but that's how it's done. It has to be done fairly, and that's the only way we can work on it at this time. I do have here information. I'm not going to go into details, maybe because Carrie is going to be sending the slides or posting them. How to find sites outside of Beaumont also, right? Like you can find sites in the county as they're expanding. It changes day to day. Usually that information is available on michigan.gov based on your zip code and what's available around you. The other thing is also, I do have details of, as I mentioned here, how does the random processes work, either by registering in one chart and creating an account, and then they send you the information when it's your time for your visit, and also that there's a 1-800 number. One thing I wanted to mention, the 1-800 number, I know there's been a long wait, but imagine 1 million people making calls at the same time. It can get overwhelming, and that's why the wait is so long, not because people are not answering the phones, because it's a choice, it's the easy choice if people don't realize how are not familiar with the electronic and how to enroll on one chart. But we also have details, and I know Carrie and other community health support groups on how to help people register if they're not IT savvy, and how they're not familiar with the process of utilizing their phone or computer to register for that. So those are things that they're working on outside of here and working with community members to help with that. But I do also have the process here of, I don't have any screenshots or anything, but this is kind of the concept of how to register. It tells you what email you get an invite, like how to register for it. And then how do you confirm your visit, and some of the questions that they ask the patient when they enroll for the vaccine. So in summary, again, safety is always our first, right, priority. And I think the vaccines both show safety, at least for the term that they have been studied. The 2-dose series is needed for most protection. 1 dose, I don't think, based on the data that I presented, is enough. And even if there's a delay with the 2nd dose, it is required and critical to get that 2nd dose if you get your 1st dose. The side effects are very mild, and it's a good sign that your body is building protection. And I always say, do not throw your mask out yet, because we still are learning, and we need to, like I said, only 2% of a very small number of our population so far are vaccinated. So it's going to take us time to get to that immune protection. And I can't have an answer if it's 70%, 80%. These numbers change as we see people getting vaccinated. Initially, we thought it was 70, but it might be changing depending on all these epidemiological data that's out there. And then, so really, it's just promoting the facts, I think, is all you can do for your groups. And that's what I do even within the hospital, right? Like there's a lot of questions even among healthcare providers or people that are very influenced with the social media. And I always say, look at the facts, just like I looked at the facts and I made the decision for myself to do it instead of listening to someone and telling me to do it. And the facts seemed very legit, and it's all about risk versus benefits, right? Like the risk of COVID is much, much harmful than the risk of a side effect from a vaccine for a day or two. That's really all I have for today. I know we're over time. I tend to talk a lot sometimes, but I can answer any questions that the group might have.
Thank you, Lama. I'm going to go ahead and just ask a few questions from the chat. I just want to first say thank you. This was a very well organized and palatable presentation. Reading through the chat, I mean, everyone has just said nothing but kind words, and just so grateful that you took the time today to share this with us. One of the first questions that we received was regarding the availability of vaccines, and you had kind of touched on it, but there were a couple of questions on Beaumont canceling around 1,800 second dose appointments due to the shortage, and just kind of what Beaumont is doing to make sure that people are able to get vaccinated within that time frame from their first to second dose.
Right, that's been, I think, unfortunate, right? Like we were all surprised because we all had to cancel our clinics. It's the state, it goes back to allocation, right? We can't make our own vaccine in any way, but I think hopefully like the registrations and also the people that got vaccinated, that information goes into MICR. So the second doses will always be priority from a state allocation perspective before allowing a first doser to get the vaccine, mainly from a protection. So it might be a delay of maybe a day. Usually we find out on Fridays what our allocation is for the next week. That's how short of a notice, and we have to create a clinic plan for that week after. So today is, what is today? Like today is the Tuesday. We found out on Friday that that was the issue. We looked at all of our patients. We even had to share supplies among each other to kind of ensure we have enough for the second dosers. But now when you don't have supplies, the second phase will be for the second dosers before. And usually like if there's an invite, it will be kind of it will be preserved there. It doesn't mean like your clinic visit is canceled forever, right? There's kind of strategic planning for that happens behind the scene. And it's just a matter of informing you. It doesn't mean like you're not going to get your second dose.
Thank you. And then just the last question that we received through the chat was regarding the AstraZeneca Oxford vaccine and why it's not here in the US yet.
I actually can't answer that right now, like in regards of why. Mm-hmm. It's probably all federal, right? Like it is something that we do have, like these were all intentionally the vaccines. It was a Johnson & Johnson, the AstraZeneca. It tends to be in Europe, like usually things get approved faster. That's just the nature of how the federal and the FDA works. Even for meds, sometimes you find medications approved 10 years before they get approved in the United States, and mainly because of that strategic, strict regulations. And I think now that we do have the other vaccines, and if we can produce all these things, it's probably just, it comes in waves how it's going to be.
Thank you very much. Those were all the questions from the chat. Is there anyone that's on the line that would like to ask Lama a question?
And I hope I simplified it. I know like I try to, it can be a lot of clinical information, but again, hopefully try to simplify like at least the mechanisms, like it's not too complicated to understand, because there's a lot that goes in depth, but I try to just use pictures to explain things to the group.
Can I ask a quick question?
Sure,
This is Faith Hott from Wayne State. My mom got her second dose yesterday, probably, just the last of the second doses. And she said that she had used the telephone number to call to schedule her original dose. And the person at the clinic said, well, that's probably a good thing that you use the phone number because the app is not working very well. So are there issues with the app that's being used for the scheduling?
I'm not aware of that, but
Okay.
I'll bring that up just to make sure there's clarification regarding that. Maybe because it was a phone call versus a random pick. I don't know if that person meant it that way.
Yeah, I think some older adults, as you probably know, are struggling with the app process, and some people have help from grandkids and some people don't. I know that's an issue for some people.
It's very, I mean, even for us, right? Like, so I think I know Carrie and Eric have been meeting with a lot of the chamber members just to kind of help promote, like maybe what's the easiest method to help people enroll. That's been, I think, the biggest, because like you said, a lot of people do not use electronics to do that. And we're working to see what methods best fit everybody's needs.
Great, thank you.
Mm-hmm.
Well, if there are no questions right now, and some do come up, please feel free to reach out and email me, and I can get a response. If I can't get the response, I can ask Lama or another one of our Beaumont Dearborn staff members to answer the question for you. As I had mentioned, this presentation is being recorded and will be up on our Healthy Dearborn website and Facebook page. And we'll also be sure to have Lama's slides with them as well.
I'll send you those as well.
Thank you.
Thank you.
Otherwise, thank you so much for being here with us today. Like I said, we definitely appreciate it. Thank you everyone on the line as well for staying the extra 15 minutes. We appreciate you being here and sharing this information with your family, friends, clients, and so forth.
Thank you.
So thank you very much. Everyone stay safe, stay warm, and we will see you next month.
All right.
Thank
Bye-bye.
you. Bye.
Be safe.
Same to you.